Hi guys, so today we will know overview of rapidly progressive glomerulonephritis. Recently we encountered a patient who presented to us with a history of rapidly rising creatinine, where the initial presentation was frothy urination, pedal edema, and the creatinine jumped from 3 milligram per dl to 6 milligram per dl over a period of 5 days. The patient presented with sudden onset of breathlessness of 1 day history, and the patient was admitted to ICU and initiated on dialysis in view of severe metabolic acidosis and fluid overload. Once stabilized, we got a initial blood test, which was suggestive of P-ANCA positive. With the background history of rapidly progressive glomerulonephritis and X-ray showing infiltrations and hemoglobin dropping from 10 milligram to 8 milligram per dl, I had a strong suspicion of rapidly progressive glomerulonephritis with pulmonary involvement. And once I got P-ANCA positive, I was confident enough that this is a case of crescentic glomerulonephritis, ANCA-associated vasculitis, or also called small vessel vasculitis, post-immune glomerulonephritis. So this is the primary diagnosis which I made and initiated on IV methylprednisolone, 500 milligrams, plasmapheresis alternative days, and IV cyclophosphamide 500 milligram. And within 2 days, the patient felt better. There was the improvement in the oxygen saturation. We also took a opinion from the rheumatologist, Dr. Binish, and we were in a right track. So what is RPGN? RPGN also called as rapidly progressive glomerulonephritis. Here the kidney function deteriorates very fast over a period of days to weeks, and sometimes they'll end up in end-stage renal disease if you don't take a proper action at the right time. So initial presentation will be a history of proteinuria, that is frothy urination, and hematuria, that is cola colored urination, and the creatinine, which will be initially 3 or 4, can rapidly go higher from then within days or weeks. The patient can also have history of fever, malaise, body ache, and weight loss. So these are the extra renal manifestations. So once we know the history, the patient has to be admitted for the close monitoring, and once we get the investigation, we have to treat them. We classify a rapidly progressive glomerulonephritis into 3 classes. Class 1 is called as anti-GBM disease or Goodpasture syndrome. Class 2 is immune complex glomerulonephritis, and class 3 is called post-immune glomerulonephritis. So this case was turned out to be class 3, that is also called post-immune, because if we do a biopsy, there is a immune bodies depositions will be less, or sometimes it is not seen, and these patients will have crescents. See, all the cases of glomerulonephritis, RPGN will have crescents on the biopsy or necrotic tissue because of severe reaction. And the treatment will be initiation of immunosuppression, mainly IV steroids, IV cyclophosphamide, and the creatinine is more than 5.7 milligrams per dl in post-immune glomerulonephritis. It's an indication for plasmapheresis, or if there is a pulmonary hemorrhage, like in this case, is also an indication to start on plasmapheresis. The prognosis is not so good because we are treating with a high dose of immunosuppression and plasmapheresis. The patient can succumb to infections, but we take all the risk managements. We put on broad spectrum antibiotics, antifungal, and we take all the measures so that patient is not get infected. This is about rapidly progressive glomerulonephritis. Thank you for listening.